and every one of you can make a difference in the agenda that we have before you today. And to start the process, we have two individuals that will make it clear to you and set the stage for you of why this is so vitally important. The purpose of the testimonial, which is the next part of our program, is to include in this discussion the population at risk. We present the problems and possible solutions to serving the underserved, the uninsured, and underinsured. But Dr. Dan Petro, an oncologist, and Ms. Donna Jones, a breast cancer survivor, who is celebrating 1.5 years of survivorship. Let's welcome them today and hear their story and hear Mr. Jones' challenges.
First, I'd like to thank Dr. Allen and Dr. Evans for inviting the two of us to share Donna's personal story with you. It's a privilege and an honor to be able to stand before you with one of my patients and to tell you about her experience and to celebrate her fight and her continued fight to overcome her breast cancer. So first, I'd like to take this opportunity to thank Mrs. Jones for agreeing to participate in this forum, to tell her personal story, and I'd like to give her the opportunity to tell a little bit about herself right now.
Good morning.
Good morning. Good morning.
As you know, my name is Donna Jones, and I'd like to thank the Gateway Medical Society for this opportunity for letting me tell my story. I'm unable, I'm sorry, maybe I'll be able to shed some light on the challenges of not having medical insurance and why I didn't have health insurance before meeting Dr. Petro.
Mrs. Jones, you don't mind if I call you Donna?
No, of course not.
Donna, please share with the audience how you and I got to meet despite not having health insurance.
Of course, as you can see, I'm a young woman, healthy. I worked hard during my years. I have a family. I'm married, mother of one. I have a daughter. She's 28 years old. And the life of why I'm really here. As part of my employee, I worked at a job for about 13 years, and they didn't have any medical insurance for part-time workers. On my own, I tried getting insurance, but it was hard for me to get insurance without any that was affordable for me.
Unfortunately, Donna, yours is a common experience. Did you, like many uninsured or underinsured people, have no primary care physician and use the emergency room to meet your medical needs?
Yes. I've always went to the medical center whenever I had any minor injury. I would go there and, get treated. but I didn't have any medical assistance.
How did you realize that potentially something was wrong?
Well, I felt I had like a lump underneath my breast, and I still didn't pay any attention. I just with doctor on it myself when it started. It broke through the skin, and I would put gauzes up underneath my breast, and I don't know if I was in denial about what I had, but this is what I was doing to treat whatever I thought I had.
When did you finally seek further attention to the potential problem?
Well, one day I was in the bathroom treating this, whatever I thought it was, under my breast, and my daughter comes into the bathroom, and she said, "What are you doing?" And I said, "Nothing." I told her, "Nothing, I'm not doing it." She said, "Well, what are you doing with the gauzes that you have?" And I said, "I'm just putting it under my breast." So she happened to see what it was, and she says, "Oh, no. She said, "I'm calling a doctor right now." And she called the doctor that she goes to over at Lincoln, Leamington office.
What did they recommend after they evaluated you?
They sent me to Shadyside Healing Center for my first mammogram, and I was 51 at the time.
Did you ever hear of the American Cancer Society's mammogram voucher program or Encore Plus's breast and cervical cancer prevention program?
No, I never heard of any of these programs until now. And while I was treating this here, once I went to the Leamington Center, the doctor, her name was Wendy, and when she sent me, told me, my husband, and my daughter that she wanted us to go to Shadyside Hospital. And she set up an appointment, called over there, and set up everything for us to go over right away. But she embraced me and my husband and my daughter so that she prayed with my daughter and my husband and me before we went over to the hospital to be treated, be examined to find out what I had.
At what point did cancer, that this might have been a cancer, cross your mind?
It never crossed my mind. Never at all. I don't know if I was naive about it or for the simple fact that I didn't have any assurance. I believe it was more so that I didn't have any insurance.
Were you frightened of the possibility?
No, I've always been, I'm a Christian person, so whatever it was, I've always had God in my heart. So I've always, whatever I had, I would like to put it in His hands.
Mrs. Jones's story is like so many other who lack health insurance. As a result, I and other medical professionals see patients who have tumors that are either too large for immediate surgery or breast conservation. With this scenario, we offered Mrs. Jones chemotherapy before having a definitive resection of her cancer. She received about 5 months of chemotherapy prior to that. had an excellent response, allowing her surgeon, Dr. Leonard Evans, part of Dr. Stephen Evans' practice, and had a great result. And she stands before you today as a survivor, and she'll continue to battle this cancer. And I'm so honored to be able to share her experience with you today. And as well, my faith with God as well has allowed us to help her today, and for her to be this messenger today to help others potentially in the future.
Thank you. Thank God for this possibility. With the help of Sandra, the patient and navigator at the Hillman Center, I applied for medical assistance. Within a month, I was able to be treated with chemotherapy and help shrink my tumor. I went through a lot with this. It really interrupted my family. We went through a lot of hardship, and my husband and my daughter and I, but we are a close-knit family. And we prayed and prayed and prayed every night. My daughter, she's my soul. She couldn't be here today, but and my sister and my mother, anything I needed financially, my sister was always there for me. And I would recommend anybody that has anything to be treated right away. Go to the doctor, get a mammogram, something that I never had. But I was able to have the doctors that I had. They were always nice. The group of doctors I had, they were real nice to me. Every last one of them. They were nice and treated me with kindness. And we laughed and joked about a lot about the situation, which made me of ease of going through this. And thank God that I made it through it and able to be here today.
So I'd just like to take this opportunity, to raise, your hand in victory. You now take.
Vice President of the Jewish Healthcare Foundation. I'm privileged to be here representing the Jewish Healthcare Foundation and our board and our president, Karen Feinstein, who is out of town today. And we rarely get asked to participate in events that take place on a Saturday, and we even more rarely accept to part in activities that take place on a Saturday. But every now and again, something comes across your desk or your email that you think, well, there's nowhere else you should be today, so this is why I'm here. I looked at the title of what it is that we're looking to address today, and it's Serving the Underserved, Uninsured, and Uninsured. And then I pulled up the latest annual report from the Jewish Healthcare Foundation, which, like the 17 other annual reports for the Foundation, includes our mission statement. And I'll quote a little bit from it. It's short, actually. The mission of the Jewish Healthcare Foundation is to support and foster the provision of healthcare services, healthcare education, and where appropriate, medical research, and to respond to the medical and other health-related needs of the elderly, underprivileged, uninsured, underserved, and underinsured people in the Jewish and general communities throughout Western Pennsylvania. And in fulfilling this mission, JHF perpetuates the vision and value of our founders and the founders of Montefiore Hospital, whose sale in 1990 enabled us to be created as an endowment for this community. This is what... So my job this morning is to moderate a panel of experts, and they are experts because they spend 24 hours a day in their jobs and in their lives thinking about these issues. So this morning we're going to be talking about barriers, and I have a stellar panel here. Their bios are in your materials, and I'm not, with their permission, not going to spend time reading through their bios with you because I trust you can look that over at your leisure. I would rather you hear from them. And I will have done my job well if you don't hear very much from me again this morning, but that we bring out information from them, and my job will be to try to field some questions for them and keep a conversation going among them after we've had a chance to hear from each of them. So I'm going to read out the order in which we have kind of selected they will speak. And first up will be Dr. Robbins, to be followed by Dr. Dixon, and then Dr. Tui Bowie. And then we'll move on to John Lovelace, and Maria Mutino, and Richard Glitch, and Margaret Rosenzweig. That's okay with you, unless, as the conversation goes, we choose to move that around. So with that in mind, I'm going to ask Anthony Robbins to come up here and set the stage for us for this morning's conversation.
Good morning. How are you? I'm going to do two things, actually, because I was assigned two responsibilities. So we're going to take care of both of them while we're here. The first one is actually going to be a pre-survey. Now, if you notice, there's a little blue gadget that's in sitting on your chair. Something looking strange with A, B, C, D, G on it, H. Originally, that, which is called a clicker, was to be used to address the question that we're going to ask of you. However, we're going to modify that because there's some challenges with the technology this morning. So, we're going to ask you to be troopers with us, and we're going to go back to grammar school. Yes, grammar school. You remember grammar school when you were given a little exam, you was like a spelling test on Fridays or whatever, and the teacher would give you a blank piece of paper, and she would ask, or he would ask, that you would number that paper and then to put a particular letter or whatever it is on that paper. Well, this morning we're going to do that. So each of you received a blank piece of paper, white paper, and we're going to do this together, and we're going to walk through these questions, and this will be our pre-test. We will not let technology stump us this morning, right? We're going to be the victors here, yes? Right? Okay, we're going to go with this. So let's get started.
Mind you, we gave Dr. Robbins this responsibility because he wanted to make sure we were an engaged audience as well as interactive.
Sometimes you should make suggestions at meetings. Just keep that in mind. Our first question, which is on the screen for you, is which best describes you? And you have some choices there, A through H. I want you to take a few moments, look over the choices that are there, and select the one which best describes you. Is it RN, MD, DO, social worker, health administrator, nurse practitioner, allied health professional, researcher, or other?
We must all participate. We will be using and tabulating this data, so it is very critical for us to receive this demographic information. Thank you.
Okay, now that you've identified or described yourself, let's move to the next question. Your demographic. Are you Caucasian, African American, Hispanic, Asian, or other? Next question. Your gender. And just write a letter down there for us, and we'll now move to the next question.
These aren't so hard, actually, so far.
Okay, not hard. Good. I think everyone's passing, don't you? Yeah? Okay, good, good. You're excited.
On the curve.
We'll take a while. Now, here's your first question. What factors impact health disparities? A, socioeconomic factors. B, health practices. C, cultural factors, D, all of the above? Just a moment more. And moving right along. How many people are diagnosed with cancer each year in Pennsylvania? A, more than 50,000. B, more than 60,000. Or is it C, more than 70,000? You're not starting to sweat on me, are you? Now to the next question. Are you ready? Let's go. What is the #1 cancer killer in Pennsylvania? What is the #1 cancer killer in Pennsylvania? Is it A, breast, B, prostate, or is it C, lung? #1 cancer killer in Pennsylvania. Next question. Do Americans know the appropriate age at which to screen for breast, prostate, and colon cancers? Is that A, yes, or is it B, no? Do Americans know the appropriate age at which to screen for breast, prostate, and colon cancers? What do you think? Okay, we'll move to the next question. Do African American men have the highest rate of prostate cancer? A, in the state, B, in the nation, C, in the world? Interesting question, especially as I am an African American male. Do African American? Oh, you didn't notice? Oh, I'm sorry. Well, I happen to be African American male, and this question is of importance to me. So, again, is it A, in the state, in the nation, or C, in the world? Next question. Black women in Pennsylvania have a lower incidence of breast cancer and a lower death rate compared to white women. Do you think that's a true statement or a false one? Again, black women in Pennsylvania have a lower incidence of breast cancer and a lower death rate compared to white women. True or false? What do you think, Dr. Cynthia Evans?
True.
We'll move to the next question. Is colorectal cancer preventable? Is that a yes or no?
I could screen that one. True.
How are you, Mr. Cephas? Good to see you, sir. Next question. What percentage of Pennsylvanians 50 and older report that they have been screened for colorectal cancer? Is it A, 70%, B, 60%, or C, 50%? And we'll take a moment more. Let's move to the next question. What is the name of Pennsylvania's free breast and cervical cancer screening program? Is it Screen for Life, B, Healthy Women Program, or is it C, Every Woman Count? Or maybe that should be Every Woman Counts. Yes? Okay. Next question. Are there enough state and federal funds to screen all 111,000 eligible women for free breast and cervical screening? Is that a yes or no? What do you think? Are there enough funds available? And if so, where are they? Oh, that's a different question. I'm sorry. Yes or no? That's what we're looking for. Yes or no? Next question. Does Pennsylvania provide free treatment for low-income, uninsured women diagnosed with breast and cervical cancer? Is that a yes or no? Next question. What is the name of Pennsylvania's statewide cancer coalition? Is it Pennsylvanians United to Fight Cancer, B, Pennsylvania Cancer Control Consortium, or is it C, Together We Can Make a Difference? I'll give you an extra minute or a little moment. Is that A, B, or C? And guessing is allowed, of course. Moving to the next question. Okay, someone threw this question in. Okay, now you know we're still a world, still a town here, but nevertheless, we need to know. Do you know the coach of the Philadelphia Eagles? Very important question for today's session. Would that be A, B, or C? Who is the coach of the Philadelphia Eagles? We're going to move on. The uninsured are young adults who don't want health insurance. Is that a true statement or a false statement? The uninsured are young adults who don't want health insurance. True or false? Next question. Most of the uninsured are not employed. True or false? Most of the uninsured are not employed. True or false? It is easy for individuals and small businesses to buy insurance. Is that a true or false statement? It is easy for individuals and small businesses to buy insurance. What do you think? True or false? Next question. There are no serious adverse health effects resulting from a lack of health insurance. There are no serious adverse health effects resulting from a lack of health insurance. True or false? What is an effective strategy for engaging community partners? Would it be identify common goals? Develop a focused strategy? Could it be value everyone's input? Or implement plans with measurable results? Or could it just be all of the above? What do you think? An effective strategy. Effective strategy. Next question. What is an effective methodology for getting community residents and clients involved in healthcare? Ambassadors, health coaches, churches, community leaders, all of the above. Could it be just one of those answers? Or maybe all of the above? What do you think? What is an effective approach in addressing health disparity? As such, which we I mean here, prevention, process, which would be intervention, results, sustainability, and D, all of the above. An effective approach in addressing health disparity. Just a moment more. Our pencils now down. Okay, we'll start with the next question. You're done. How about that? We'll actually share the answers a little later in the program, but we'll make sure that you give those sheets to the volunteers. Yes, they'll be picking them up shortly. Now to the second assignment given, to participate on the panel. Anyone who reads the local newspaper, engages the popular press, or scans national media is often struck by the persistent widening differences in health status between African Americans and whites. These images and stories give light to the problems of those who combat poor health outcomes. However, these chronicles do not address the size and changing nature of these differences, nor give their causes and effects. Poor, working poor, middle class, wealthy, it doesn't seem to matter. African Americans on average die younger than whites, regardless of the money they make or the neighborhood in which they live. In Allegheny County's poor neighborhoods, whites live almost 3 years longer than blacks in the more well-to-do neighborhoods. This gap grows into a chasm. Whites live to an average age of 76.4 years compared with just 67.1 years for blacks. That's a difference of 9.3 years. Nearly a decade of life gone. You could say this is the new civil rights struggle. African Americans lag behind on nearly every health indicator, including life expectancy, death rates, infant mortality, low birth weight rates, and disease rates. We have shorter lives. We are quite literally dying from being black. A black baby born today can expect to live 72.7 years, while a white baby is expected to live to be 78. If you consider the American Indians and Alaska Natives, which we have very few here in the county, their life expectancy is even more bleak, 70.6 years. But at the other end of the spectrum, a newborn Asian American girl can be expected to live the longest, until 85.8 years. There's no single reason for these disparities, but rather a complex set of social, economic, educational, cultural, and racial circumstances. A lack of health insurance, a distrust of the medical establishment, poor personal choices, and inferior health care all are factors. This begins a myriad of questions around health disparity. What is health disparity, by the way? Health disparity can be defined as the difference between the average disease burdens found in various groups. For example, every group will have its own normal rate and innate differences around that rate, known to many of you as the standard deviation. But disparity is the amount of differences beyond these innate rates or differences. More specifically, it is examining incongruity, imbalance, and barriers, whether they be biological, behavioral, physical, or social, that affect outcomes within a group, and then comparing these differences to another group. Pick almost any disease, and blacks are hit much harder by it than whites. Consider these statistics from a variety of national, state, and local organizations. Heart disease. Nationally, African Americans are 50% more likely to have high blood pressure, which contributes to the risk of both heart disease and stroke. And they're 20% more likely to die from heart disease. Yet, they're less likely to receive proper, timely treatment, even when they have insurance coverage. Stroke. In Allegheny County, African American men are 53% more likely to die of a stroke than any other racial or gender group, while African American women have the highest overall risk of a stroke. Diabetes. Nationally, blacks are 140% more likely to be diagnosed with diabetes, 30% more likely to undergo a diabetic-related amputation, and 120% more likely to die from diabetes. Cancer. Whatever the cancer. Lung, breast, colon, esophagus, bladder, cervix, uterus, rectum, prostate, leukemia. Blacks are less likely than whites to be alive 5 years after diagnosis. Even skin cancer, which is uncommon in those with darker skin, is more likely to end in death for African Americans. HIV/AIDS. Of all racial and ethnic groups in the U.S., HIV and AIDS have hit the African American population the hardest. The reasons are not directly related to race or ethnicity, but rather to some of the barriers faced by many African Americans. These barriers can include poverty, sexually transmitted diseases, and stigma. When we look at HIV/AIDS by race and ethnicity, we see that African Americans have more illness, even though we account for about 13% of the U.S. population. African Americans account for nearly 49% of the people with HIV/AIDS. Shorter survival times. African Americans with AIDS often don't live as long as people of other races and ethnic groups with AIDS. And more deaths. For African Americans, this is one of the leading causes of death. What about infant mortality? Even though infant mortality declined steeply in the 1980s and 1990s among all races, the disparity between whites and African Americans increased because the improvement was greater among whites. In each of the categories or disease categories I just described, the Hispanic and Latino populations follow a close second. While imitation is the highest compliment, here it could be to their detriment. The statistics that I've shared are numbingly clear. It doesn't matter what diagnosis or health condition. It doesn't matter how you measure it, whether you measure it by the amount of care, the quality of care, the appropriateness of care. It doesn't matter whether you look at it at different geographic regions. The answer is still the same. The picture is still the same. It's everywhere. And of all the indignities African Americans have confronted in this nation's history, from slavery to segregation to inequality in housing, education, and income, the health gap is one that has remained virtually unchanged. Surprisingly, health disparities may be even more resistant to change than other social problems African Americans have faced. In conclusion, health disparities have been identified. Now we need to move to action steps, a model. Let's get innovative. Let's put the public back into public health. We need to create models that work for our people. Let's get busy.
Dr. Bruce Dixon needs no introduction.
Okay, I'm just going to put our
back up. Well, you put your things up. Okay, I have to tell you, in a former life, and not so former, that Anthony worked for us as an epidemiologist at the health department. You can see the place hasn't been quite the same since he left. A lot of level of enthusiasm and excitement to the department. I think the one day he came in for a national site visit dressed in a dashiki was a little bit of a peak of his career, but we certainly got the grant, and I think they were impressed. And they did a great job. Well, it's a pleasure to be with you today, and Mrs. Jones, we're terribly grateful for your coming and sharing your experience with us, because I think your experience really caps what Anthony has pointed out in the numbers and what our concerns are in this community. I think we have some unique opportunities in Allegheny County that the other parts of this country should be envious of. We have problems, clearly, as Anthony has related to you, but they're not so far out of control we can't do something about them. And we've always worked together as a community to try and address problems, and I think that that's certainly a model that is to be replicated. I was happy to see Maddie Woods here a little while ago. She was one of our original board members from our Healthy Start project. That project was one of the only projects in this country that reduced African American infant mortality by 50%. It certainly did not equal the gap, but other projects couldn't come close. And the reason that project worked is something that we started basically when I took over as director of the health department. It's something I sincerely believe in, that the community has to be a part of any solution. And that model has been replicated in other areas in both the health department here and now in other parts of the country. For too many years, we've had a top-down approach where people who had the responsibility were telling other people what to do rather than listening the opinion of other folks to figure out what the best solutions are. And I think that that becomes a model that we need to continue to foster and we need to continue to perpetuate. I was surprised in reading the paper this morning that our I have to watch what I say now because I don't want to get in trouble with some of our political leaders. But they're going to solve the problem now, once again, of youth violence. We've been trying to solve this for I don't know how many years. And we've not made one bit of difference. Because we have not really gone out and identified what the root causes are. And the root causes are social problems. They're not medical problems. There are issues around employment. There are issues around economics. And I think this underlies a lot of the health issues that we see in some of our minority populations. And let's be blunt about it, in Allegheny County we're either black or white. We don't have a significant Hispanic or Asian population thus far, and those few members of the Asian population, by and large, are able to get health care because they're fairly affluent. I think there are growing other minority populations. As Nancy points out to you, there are people of multiple cultures coming in here. But still, our major problems in this county have to do with African American health. And I think until we get a significant, large component of African American physicians and health practitioners to take care of people, we are not going to have the successes that we want to have. But let's be very clear about it. There are cultural, racial differences between people, and people feel more comfortable seeing somebody who looks like them, who understands them culturally, who understands them in a variety of ways that the majority population sometimes does not. I have to tell you a somewhat amusing story, at least I found it amusing. Some years ago, a man I've known for some period of time, and he periodically goes off the deep end. Took off his clothing in the middle of December, African American, and ran down the street in Wilkinsburg. Not a good thing to do. The police came and arrested him. At the time, we had these catchment areas around the county, and his particular catchment area hospital was full. So he was taken to St. Clair Memorial Hospital. How many African Americans do you think they've seen out at St. Clair? Not too darn many, I can somewhat assure you. He called me and says, "Get me out of here." I said, "I can't get you out of here. You're there on a 302. Behave yourself, and maybe they'll let you go in a few days." More interestingly, though, the psychiatrist called me and said, "This man is really very bizarre." I said, "Well, how is that?" Well, he says he wants to have sex with me. Well, something strange about this. He's not into guys, and I don't think he's into older white guys, if he were. I said, "Well, how do you read that?" And he says, "Well, I was talking to him, and he says, if I didn't let him out of here, he's going to F me up." It seems to me, I can perfectly know what the guy was saying. This guy had no understanding whatsoever. And how can you deal with somebody's mental illness if you don't understand them culturally and where they come from? So I think we need to get a component of people who are sensitive. They don't all have to be at the same place, but they need to understand some of the patients they're taking care of. And I think that's terribly important. The other thing I think is important to recognize that in the whole priority of things, healthcare sometimes takes a back seat. If you don't have enough money to be able to eat, to pay your rent, to pay your mortgage, to get the basic necessities of life. And until we deal with some of these problems, I don't think we're going to have equality in health care. Anthony's pointed out some of the disparities. They're clearly there. There's no question about that. Our responsibility as a health department is basically as an assessment agency, and we do this with regularity. We put out reports, we put out the numbers, I've had to rebuild an epidemiology section since Anthony and somebody else left. But these are things that we have regularly done. And we do have the disparities that are pointed out. But I would submit to you that until we start to deal with the core issues that result in some of these disparities, we're simply putting frosting on the cake and we're not dealing with the basic underlying things. So I'm always grateful to see a growing number of African American physicians training here, coming and remaining in this area. I guess I'm one of the oldest ones around this place. Any of you remember Dr. Greenlee?
Oh, yes.
Or Dr. Hairston?
Yes.
Or Dr. Miller?
Yes.
Or several others?
Dr.
Those-
Hale.
Dr. Hale, the Nickens brothers. Those were the pioneers. Those were people who really worked to try and improve the health of our minority communities. And we're grateful to all of them because those are the people that started this and those are the ones that you're following after. So aspire to be as good as they were and continue to grow from there. I'll be part of the panel, but that's my discussions for the moment. Thank you.
Good morning. It's hard to follow Dr. Dixon. It's great to be here with friends and colleagues, especially those who are with the community health centers, the safety net in this community. And I had my start there, and I'm always a big supporter of the community center system. But one thing, before I start, when you hurt, it's important to have a Band-Aid. But that's not the answer. So please keep in mind that it's time for change, and we should look at the bigger problem and look for bigger answers as well, while we continue to do what we're doing as all Band-Aids, as a safety net provider. So I'd like to talk about two groups, two underserved groups in Allegheny County. They're small, but we work with them closely at the Birmingham Free Clinic. And I'm sorry, but sometimes I feel like because I have an MD that I asked to be on panels, but the work at the Birmingham Free Clinic is by volunteers, health professional students, lots of people who have given a lot of time and generosity. So I'm here on behalf of them, not as an expert. So we've been fortunate to work with the Spanish-speaking uninsured, particularly those who are undocumented at the Birmingham Free Clinic. And really, it's medical students who come to us and ask, and started this, and we just kind of help them along together with many other groups in Allegheny County to serve these populations. The last estimate, I believe, is about 30,000 Spanish-speaking individuals in Allegheny County. And in the other group that we started to work more in collaboration with Catholic Charities and the Squirrel Hill Health Center and others is the recent refugee populations. A lot of our Somalis, Bantus, and Burmese, and also the latest is the Burundian and the Burmese refugees. So one thing that we struggle with, and I'm kind of throw these out as some of the challenges and barriers, is for those patients who are undocumented, it's really difficult to get them services, get them medical assistance and access to other social services. So we do the best we can. For recent refugee populations, I think one of the biggest issues is lack of professional interpreters. Okay, there are some out there, but it's not enough. The other thing that we see is due to Pittsburgh geography and the few places that serve these populations, transportation is a big issue. A lot of our, for example, Burmese and Somali refugees are placed in the South Hills, and for them to come to, for example, the Squirrel Hill Community Health Center, or Birmingham Clinic, or any of the facilities in Oakland or in East Liberty, Lawrenceville, I mean, it's a challenge to get here. The third thing is a lack of mental health services. That's one thing that maybe one of our panelists will cover that more, but we struggle with that. It's not enough bilingual or very culturally, I hate to use the word competent because it implies something. I'm trying to, very culturally sensitive or aware therapists or mental health professionals. So that's something that I hope we can come up with some solutions and some action plan. And then the last thing is the training of students and other health professionals to be more culturally aware of some of the issues facing these various populations. Because we don't have a critical mass here, we're not like other big cities, you know, Minneapolis, St. Louis, other places that have been touted to have a very good kind of system to serve refugees or recent immigrants. So those are what I want to lay out for the audience. At the Birmingham Clinic, we see a lot of about half of our patients are from rehab program. I think I'm honored to say that actually most of my patients are underserved minorities, and when they call me Dr. Twee, actually I felt like I already connect with them, so a lot of people know me as that. And actually, I'm there just to sign these medical assistance forms. Most of the time, that's what I tell my staff. Just conclude with a quick stories. We have a lot of residents in training at the Birmingham Free Clinic, and they always struggle with signing the medical assistance form because they said, well, you know, are we enabling them? Are we, you know, da-da-da-da. And I said, you know, if they have, you know, a medical condition that you think will benefit by having health insurance, by having follow-ups and photo care or testing, then you should not have any ethical or moral dilemma about signing the medical assistance form. We, as a government, have spent so much more money on, okay, I'll stop there, on other things. So, we will, thank you.
A bunch of hard acts to follow, I'll tell you. I was asked to talk this morning about adolescent substance abuse and disparities in care, but I'm going to do that a bit, but since I'm here, of course, now I can't stop. So I warn you a bit about the Joe Biden School of Public Speaking. So I'm waiting for Nancy to sort of pull me off the stage here. I can get a little revved up about this. Here's some good news. In the public sector, in drug and alcohol services, there is not a huge, even a notable difference in access or engagement of services in adolescents based on race. There are some differences based on age. Younger children are more likely to be engaged in services than older, but there are also many fewer of them. There are not a lot of drug-abusing 10-year-olds. There are some, more than you'd think, I suppose. There's some differences based on gender. But there are not very significant differences based on race, which is sort of the good news. The bad news is there's not enough service for everybody. So one of the major efforts on the public side with the county behavioral health program as well as the Medicaid behavioral health program, which are the people who serve the underinsured, the uninsured, and the insured as well, there still is much work to do in terms of recognition and engagement of substance abusers in effective treatment. Particularly in terms of retention. Some of the work we've done publicly is we've focused on not only engaging people in care, which is a big challenge, but also retaining people in care. And I'm sorry to tell you, on the retention side, despite a big effort to move this, the number of people, the portion of people who started drug and alcohol treatment who are still in treatment 90 days later, which is sort of the evidence-based marker of likely to succeed, is something around 20%. That is to say, 80% of the people who start aren't there 90 days later. But particularly as people leave detoxification programs. They're very common that people just never reappear again. And part of it is because the patient didn't really want to move forward into an engagement recovery idea. They wanted to detoxify, but they didn't want to move forward much differently. But there are some other major differences I want to talk about as well. One is related to Anthony's point earlier, so the same theme. People with chronic mental illness die 26 years earlier than their peers without chronic mental illness. Not of their mental illness, they die of physical conditions. It's not a huge number of people, so 1 or 2% of the population probably, but it's a very, very significant challenge to the public health and medical system to try to engage people differently. The theme of this, I think, is really engagement. I had a meeting yesterday with Maddie Woods and some of her colleagues. It was kind of our same discussion. We have lots of tools. We have not much skill as a system at engaging people in effective care. Even people who are insured. We had a discussion not too long with the welfare department around outreach efforts in cancer screening. And so we're looking at the medical assistance population, and Maria's situation may be different than ours, but if we look at from the physical health side, the proportion of medical assistance recipients who have cervical cancer screening is something under 40%. Not because they don't have coverage, because they aren't engaged in healthcare. Proportion of women who should be having breast cancer screening is something around 50%. Of people who have coverage. It's not that they don't have coverage, they could, there is a way to pay for this. People aren't engaged in identifying the problem, so Anthony's quiz, question 27. And the same is true of colorectal cancer screening. Those questions got harder as we went along, especially those. I was waiting for the A, B, but not E. Sorry, A and C, but not D. That's the post quiz. We're making sure Rodney gets graded on the curve here, so he looks good when he goes home. I do want to point out, as I move forward this in behavioral health, some other racially based disparities that are important and do need to be addressed. And a couple of them are related to timely follow-up care. African Americans are 30% less likely to have timely follow-up care for behavioral health intervention than Caucasians are. And as other people know, this is largely an issue of African Americans and whites. The other populations are very, very small, so hard to do anything statistical with that. The people being discharged from substance abuse, African Americans are 13% less likely to have timely follow-up than Caucasians are. In terms of adequacy of care, African Americans are 34% actually less likely to have an adequate dose of psychotherapeutic care for depression than are non-African Americans. These are almost all related to follow-up issues and engagement, I think, in terms of how people are not successful. I want to talk a little bit about some solutions, or some trial solutions at any rate. And there are lots of other statistics that are sort of the same about fall-off rates, disappearance rates, engagement rates. We believe one of the causes of this, one of the barriers to care is, if you will, especially behavioral health, kind of the specialist model. If you're in a primary care setting, we have a project we're doing with our colleagues in the other managed care plans, the Rand Institute, the county, around screening for depression in pregnant women. In the second phase of the pilot project, which is one of the projects was the East Limley Family Health Care Center, where Dr. Hall hangs around in his spare time. The practices were very good at screening women for depression, but nobody ever went to treatment. I don't exaggerate, not nobody. Hardly anybody went to treatment. Because to go to treatment, you have to get another bus, and you have to go to another place, and meet another set of people who start your story all over again, and people don't do it. So one of the solutions to this, we've been working with a bunch of folks, is trying to move behavioral health services into primary care, not move patients from primary care into behavioral health services. That's a particularly effective method, generally, of intervention with people who are minorities, because it's about having a relationship. If you have a relationship in the primary care side, moving a specialist thinking into that is more likely to engage people than moving the patient to where the specialist is. That, of course, is premised on the idea that the patient is engaged with a primary care person to begin with. And you've already heard that there are differentials there as well. We've really tried to develop some services other than treatment. Services are more on the support side. Services that focus on peer supports. Whether it's peers who have a same condition, peers who are in recovery from the conditions, the breast cancer survivors supporting people with breast cancer, drug and substance abusers in recovery supporting people in early recovery, in a different support system than a professional system gets, which is a treatment focus. Certainly improves both follow-up rates and improves, in the case of substance abuse, the sort of the consequences of substance abuse, such as joblessness, homelessness, familylessness, if there were such a word. That people get more engaged in the living part of their lives, not the treatment part of their lives, as well as on the treatment side. There are plenty of opportunities to improve access to health care. The focus, I think, that makes more sense to us is both in developing some tools, but also really in how people are engaged differently in thinking about healthcare, so that we're not, as Mrs. Jones was describing, we're not in denial because I can't afford this, or I don't think it's, I'd rather not think about what this is. I just actually I went to get a lab test last week. I got my envelope back from the doctor's office. I ran to the doctor the other day at a meeting, and he's saying, it's one of the envelopes, do I want to open this or not? This could be good news, could be bad news. Hold it up, Karnak, and hold up your head. Turned out to be good news, luckily, I'm still here. It wasn't a life-threatening condition anyway, but you don't want it to be bad news. About the whole idea about engaging people in care differently is a message I'm sure Dr. Johnston will talk about at noon. The Governor's Chronic Care Commission has a whole subcommittee on consumer engagement. I've been active with developing methods and information and organization around how your participation in your own health care is a major issue for everyone, whether you're uninsured, underinsured, underserved, minority, or majority. And so I challenge us to think about other ways to engage people in healthcare, to identify what's important, to work on prevention. This is not only a matter of being treated when you're ill, it's a matter of anticipating how lifestyle choices affect illness, affect health, and I challenge us all to move forward and make a step up. So, thank you very much.
Good morning, everyone.
Good morning.
I want to thank Dr. Allen and Dr. Evans for the privilege of asking Gateway to participate in this really unique symposium and interactive educational program. I'm going to share with you some of the background of Gateway Health Plan and then discuss some of the areas that we've tried to address healthcare disparities for our members. Gateway Health Plan is a Medicaid MCO and provides services to medical assistance recipients. And in 2006, we expanded our line of business to include the Medicare Short Advantage program. Our Pennsylvania Medicaid membership includes approximately 315,000 members. 22% are Afro-Americans, 12% Hispanics. Our Medicare Assured program has approximately 25,000 members, and they include 13% Afro-Americans and 16% Hispanics. 30% of our membership resides in 2 counties, Allegheny County and Lancaster County. 50% of the Allegheny County consists of Afro-Americans and Hispanics. 35% in Lancaster County. We understand there are certain barriers for our membership at Gateway Health Plan. Some of them include the low health literacy, members not feeling empowered to ask questions, transportation issues, child care, socioeconomic factors, but more importantly, we've discovered are the priorities in a member's life other than their own health care needs. We've learned that it's important to meet the member where they are. That is the reason why Gateway Health Plan developed Prospective Care Management, or PCM, model, and that is currently our business model. PCM is a proactive approach to health care that identifies the issues a member faces and then designs a plan to ensure that that member receives the care he or she needs. The goal of PCM is to improve the health and well-being of all our members. Our staff assesses the member's needs using a holistic approach by gathering information through the BEAMS. The BEAMS is an acronym that stands for behavioral, environmental, economical, medical, social, and spiritual. We believe that obtaining this information about each member will enhance and improve the quality of care for all our members. The disease management program that I've been involved with that has made instrumental progress in addressing our healthcare needs is the Maternity Outreach Management Program, or the Mom Matters Prenatal Program. This is a comprehensive program of maternity care coordination developed to improve the frequency of prenatal and postpartum care, reduce the incidence of low birth weight, reduce the incidence of preterm deliveries, and address NICU admissions. All identified pregnant members or mothers are enrolled in the program unless they decline. Otherwise, they receive various interventions based on 3 stratification levels: standard, moderate, and high risk. Gateway Health Plan formed the Women's Advisory Health Group to oversee the Mom Matters program. The work group consists of physicians and nurse practitioners representing the following areas, including OBGYN, family practice, internal medicine, neonatologists, as well as our staff members from disease management, preventative health, pharmacy, QI. I also chair the perinatal NICU Perinatal Advisory Work Group, which is represented by neonatologists as well as perinatologists. Both advisory work groups collaborate together to address our pregnant members and their newborns. Over the past few years, we have looked at ethnicity at our prematurity population. In 2007, Gateway Health Plan's prematurity rate was 11.4%. The prematurity rate for Afro-Americans was 14.3%, and for Hispanics, 10.5%. The Pennsylvania prematurity rate and national prematurity rates, based on the March of Dimes data in 2005, show that Afro-Americans' prematurity rate was 16.8% in Pennsylvania and 18.1% in the nation. The Hispanic prematurity rate in Pennsylvania, 13.2%, with a national rate of 12%. In collaboration with the Women's and NICU Perinatal Work Groups, we believe that the Mom Matters Disease Management Program has been influential in addressing Gateway Health Plan's membership needs for our pregnant women and their newborns. The interventions from this program have improved our prematurity rates in our pregnant mothers, not only across the plan, but also in the Afro-American and Hispanic populations. Aligned with Gateway's PCM approach, or the Prospective Care Management approach, of meeting members where they are, race data is included in the Care Gap outreach reports. This report is utilized by Gateway's Care Management team to outreach to the head of households and address the gaps in care. The approach allows the outreach representative to discuss gaps for all Gateway members residing in the household. An example would be to educate and coordinate the scheduling of a mammogram for the mother in the family, and also the well child visits that are necessary for the children. The addition of the race data to this report will allow the outreach staff to identify the race prior to the call and to apply cultural relevance. But more importantly, to meet the member where they are. This data will also allow us to measure screening and contact rates by race. Outcome results will assist in developing targeted populations and targeted interventions. Gateway may utilize the data for staff assessment to match appropriate staff to the member's special need. Designated staff for this outreach approach may be assigned to certain populations. Gateway will add ethnicity data to this report in the future. The care management team currently employs a Spanish-speaking outreach representative to align with Gateway membership language needs. We also have several staff in member services that are Spanish-speaking. Gateway also recognizes the need to educate staff about healthcare disparities. The clinical staff at Gateway will participate in training on healthcare equity and inequity, impact on Gateway's work. The staff will also preview the DVD Unnatural Causes, produced by California Newsreel and seen on public television, WQED. We have also partnered with the Disparity Solution Center at Massachusetts General Hospital. This is the first hospital-based center in the nation dedicated to developing and implementing strategies to eliminate racial and ethnic disparities in healthcare. The DSC, or the Disparities Health Solution, has developed a disparities leadership program. The goal of this program is to create healthcare leaders to have a comprehensive knowledge of the causes and research surrounding healthcare disparities, to develop quality improvement strategies and skills to address disparities, and to develop the leadership skills to implement solutions to transform organizations. We have members here today, Monica Reese, who's part of that DLP program at Massachusetts General Hospital, representing our organization as I do. Gateway has recognized, and 1 minute and I'm done. We have recognized that there is a care gap in our population. In 2008, Healthcare Disparities Work Group has been developed for the purpose of identifying significant differences in care and outcomes based on ethnicity of our Gateway membership. The goal is to use the information to focus on areas with largest disparities and to develop long-range intervention plans. One of the goals of this initiative is to identify and catalog sources for capturing member demographics related to race, ethnicity, and language needs. Gateway will also identify key quality measures to begin to stratify based on race and ethnicity and complete a gap analysis. Recognizing the need to approach disparities from a member and provider perspective, we will identify and catalog physician practice network data related to race and ethnicity, and will conduct an analysis to identify practices serving the highest volume of our diverse population for targeted physician interventions and outreach activities. Thank you.
I'm Dr. Richard Fletch. I'm the National Dental Director with United Concordia, which is the dental subsidiary of Highmark. I wanted to thank the Gateway Medical Society for having a speaker address what I consider, and I think many consider more and more, a growing problem in our society, and that would be oral disease. I'm not going to, as a dentist, I'm not going to stand up here and tell any bad jokes, because I think our profession is probably the brunt of as many as any. And having worked in Washington, D.C. inside the Beltway for about 30 years, you pretty much hear a wide range of jokes from, we won't even talk about lawyers, but having physicians in a chair, it's always an interesting situation, the perception of professions, especially dentistry. One time a physician is in the chair and finished up with some things, including a minor surgery, and he looked at me and he said, "Doc, I just don't know how you can do what you do. I mean, it's so close. It's just, I just don't understand how you can do what you do every day." And that came from a proctologist. So, again, perception is something that I would just like to possibly open up to you all today as far as oral disease, why it's important. We don't deal with too many chronic diseases in dentistry. We deal with two primary chronic diseases. One is dental caries and the other is periodontal disease. But if we had a question up here as far as the #1 disease in children, I don't know how many of us would probably put down dental caries. That is the #1 disease in children today. So much so that it's now an outdated study. It's a few years old, but NIH ran one that said that 51 million school hours were lost. 51 million years ago, so that's gone up, strictly from dental problems in children. So we're talking about, again, like so many diseases, we're talking about a disease that's concentrated in a subset of children, and there's wide variation by race and income, like so many of the diseases that you all have to deal with. People tend to make light of it, but dental disease is consequential. We're talking pain. We're talking pain. We're talking the inability to function. Many of us probably have experienced that to a degree. Think of it when you're a small child and what that does to you with your learning, with the way you think about yourself, with the way you think that you're fitting in to your peer groups. We won't even go into letting oral problems escalate like they did in the Diamante driver in Maryland, a 12-year-old African-American child who, interestingly enough, some people don't know this. His mom took his younger brother to a dentist because his younger brother had pain only weeks before. Diamante, I guess maybe he was one of those kids that just didn't complain. Let things go. Tooth abscess, straight to the brain, died. So, we're talking about something that goes through different families, communities, societies. And we're talking about something that's predictive of future diseases. I mean, caries in general, people think, well, caries, decay. Well, no, caries is the disease. Decay is the result of the disease. What we as a profession have failed is that we treat the cause of the disease. We don't treat the disease itself. It's like, think of a burning house. We keep putting new roofs on that house. We never look at the fire beneath. We need to put the fire beneath out. We need to develop more preventive versus the surgical interventions. And the frustration is that we know that the disease can be stopped. We know it can be contained. We know that it's infectious. Caregivers actually give dental caries to their children. Children are not born with the bacteria in their mouths to cause decay. Here, honey, let me put a little taste. Let me taste your food first. Give me a big kiss. The saliva content of the caregiver transmits their disease process to the children. So we know it's infectious, we know it's transmissible, we know it's diet dependent, and we know it's fluoride mediated, yet we can't seem to get a handle on this. The fluoride community, the fluoridation areas, those communities have helped big time. But as some of those children rate, low percentage of us that have gingivitis, just a minor inflammation, 35% of the population have periodontal disease, and of that, the 7 to 12%, very severe. Very severe. It goes in, this perception thing, it goes into some of the barriers. The lack of understanding of the problem. We need to get that message out to the public. We need to get that out to the caregivers. We need to get it out into the professional communities across the board. Physicians, dentists, nursing, paramedical. We need to get it out there and into the communities also. Other access problems we know. Population's going up, dentists are going down. That's a fact. We know that, I tend to think that, I call it rural inner city, because there are inner city areas that are considered rural because there's just not enough dentists to treat X number of people in their population. So I refer to it as the rural interracial, inner city problem that we have. And yet you'll have certain people say, well, there's no problem. There's 85% of dentists that are in urban areas. Unfortunately, 95% of those are associated with private practice. Yeah, but I saw a survey, 96 to 97% of the dentists in Pennsylvania, they're accepting new patients. And that's if you eliminate medical assistance and CHIP programs. So we've got a problem with access. There's a stigma attached to the dental profession in treating medical assistant patients. Reimbursement is one issue all the time. All the time. But that's not the key. I've talked to time and time in dental groups, and they say, you know, I don't even mind taking less money. I know these people need help. If the government could only get rid of all the administrative hassles to treat these patients. Besides in Washington, I had another small practice here in Pennsylvania. I tried to give back to the community. I grew up in a steel community. So I was crazy. I was back and forth in both offices until kids came, and my wife said, you better start to get a job or something. I used to treat medical assistant patients free. I didn't spread the word on that. But it was such a hassle for me to get those few dollars from the state. It wasn't worth it. Now, I would direct them if they needed more care, of course, but to me, as a practitioner, that's still going on 30 years later. So I'll throw those out again, just possibly as a perception on yet another problem that we face in the healthcare field, and just leave it at that. I want to again thank you all for inviting me.
Good morning. I'm Peg Rosenzweig. I'm very honored to be here today to discuss the role of nurse practitioners in ensuring access to quality care for all individuals. The nurse practitioner role was first developed in Colorado in the early 1960s to meet the needs of pediatric populations, and particularly underserved populations. The role quickly grew, and it started to encompass adult, family, and then acute care and more specialty type practices. It's unusual today to see any area of healthcare where there is not a nurse practitioner trained to deliver care in that setting. As the role has increased, there's been increased utilization of nurse practitioners to meet the needs of underserved throughout the country. And indeed, literature does reflect that the non-physician practitioners are increasingly utilized to meet the needs of underserved or under-accessed populations. As the role has increased for nurse practitioners, there's been some concern about quality of care. Is the utilization of nurse practitioners in care a sort of a poor quality care if it's not physician care? The literature recognizes that there's probably about 80% of primary care practice that can be safely conducted by nurse practitioners. This is for a large part the management of chronic care that often requires a lot of communication and sort of teaching components so that nurses are really utilizing their more holistic background. The literature does document that head-to-head competition between physicians and nurse practitioners, whether that be in a house staff or medical teaching arena, or physician versus nurse practitioner, or training fellowship versus nurse practitioner, that the medical outcomes are the same. So there's not poor quality care, but that nurse practitioners do win a little bit in the satisfaction with communication and with families and patients, and in adherence to therapeutic regimens. And so these are not really soft quality indicators because we recognize more and more about the importance of communication as a quality indicator, as evidenced by the inclusion of communication in medical school curriculums, and as the federal government now recognizing that as a quality outcome. And so if we can say that nurse practitioners can safely deliver care, then why can't we utilize nurse practitioners more to solve some of the problems in delivering quality access care to all individuals? Well, there are many barriers. The first is education. Nurse practitioners require a master's degree in nursing. And so we have nurses who are, for the most part, working and trying to come back to school to get a master's degree. These are not the kinds of online programs that you can often do for more and more master's degrees these days, because they're clinical degrees. So we need to see the nurse practitioners doing physical exams and in the clinic seeing patients. They have to have clinical hours. So these are pretty labor-intensive master's degrees. They're expensive. The program at Pitt costs about $50,000 to get a nurse practitioner master's degree. And the barriers to care, or for nurse practitioner utilization, is really state to state. Pennsylvania is one of the more traditional states in terms of allowing utilization of nurse practitioners. Until the year 2000, nurse practitioners did not have prescriptive privileges in Pennsylvania. And we were one of the last 2 states in the country to allow prescriptive privileges for nurse practitioners. Since then, since 2000, there has been increased utilization and increased recognition of the need to allow nurse practitioner practice. And particularly through Governor Rendell's health reform policy, he has recognized that there will really not be access for all individuals without increased utilization of non-physician providers. And so the Healthcare Reform Act specifically mentioned the need to allow nurse practitioners and non-physician providers to provide care and to relax some of the rules surrounding that. And so the House bill for nurse practitioners that has really been championed and that we're very happy to see passed was House Bill 1253, which allowed, across the board, a lot of relaxation of some of the barriers to care. So some of those were kind of silly, like nurse practitioners couldn't order durable medical goods or couldn't order home care. And so nobody really had an objection to those being relaxed. But some of them did include reimbursement by third-party providers, and that there was a relaxation of the ratio for physician supervision. So in Pennsylvania, it used to be 4 to 1, and now there is not as a ratio for supervision, so that physicians can supervise any number of nurse practitioners. There was a pushback from medicine about that, and so nurse practitioners do have to carry their own malpractice insurance. That was part of the bill. Additionally, Governor Rendell has continued to speak out in favor of nurse practitioners and non-physician providers in terms of providing access to care. Some of the other barriers are increasing tension between medicine and nursing. As the healthcare dollars have continued to shrink, there has been more and more concern among the larger medical organizations about the utilization of non-physician providers and an attempt to sort of define that practice. And of course, nursing doesn't want to have medicine define practice, so there continues to be tension about that. And nursing is creating some of their own barriers in the development of the doctorate in nursing practice, where they're asking nurses who want to become nurse practitioners to have a doctoral degree, a clinical doctorate, as sort of an entry to practice. And that's because there's a worry that nurse practitioners are so clinically oriented that they're really not taking the seat at healthcare. So they are very good and excellent clinicians, but they're not sitting at the table, kind of in the practices, making decisions about patient care. They're not really able to analyze their own patient practices and patient outcomes to improve care. And more importantly, they're not seeing the big picture, the global picture, and not part of healthcare solutions. And so the hope is that a doctoral level degree would add more education, more training in order to assume those skills. That does create a barrier, though, for education, for cost, for time, and for the putting more nurse practitioners into the workforce. So we have our work cut out for us. There are solutions. Some of the bigger solutions can be money for nurse practitioners to head back to school. Creative programs with scholarships that could allow practicing nurses to insure time after they are nurse practitioners, but continue to allow them to go to school for 2 years full-time, get that schooling done, and then work for the organization as nurse practitioners and to absorb the cost of that education. There are solutions for better dialogue between physicians and nurses and not all this tension. If our goal is to ensure quality care, we need to work together for those goals and not worry so much about the territory. This can be done collaboratively and certainly to ensure quality care for everyone. Thank you.